So I will start sharing my screen and we'll do an opening for our session. Okay, so welcome everyone to our series on equity and reproductive health services for women with substance use disorder. This is the first one in a series of 6, and they will be on the 3rd Wednesdays of every month until December from 1 to 2:30 or 1 to 3 like we are having today. And this is a collaboration from the Center for Public Health Practice and the Center for Health Outcomes and Policy Evaluation Studies at The Ohio State University. I want to thank all of our planning partners. There were a lot of them and everyone was really helpful in not only getting speakers for us, but providing direction and guidance for the content of the series. So there's some technical information I would like to share with everyone, and some of you already asked these questions. The sessions will be recorded and emailed out. They will also be posted on our website, which I will share at the end of the session. Slides will be available after as well, and they will be posted on the website as well. All participants are automatically muted and video is disabled, but if you're unsure, you can look at your screen, and if there's a little microphone with a line through it, that means you're muted. But right now I don't hear any background noise, so everyone is doing great. We have a Q&A function for you to ask questions. You can also do it in the chat function, but the Q&A function box will be monitored by our team. If you have a specific person you would like to direct the question to, you can type their name and we will ask them directly. If not, I will just take initiative to direct the question to whoever I think would be best to answer it. And then also give the speakers equal amount of time. And then for those of you wanting CEUs, you have to complete an evaluation that will be emailed by me after the session. And then we'll ask you for your license number and all of that, and get you out your certificate after it's reviewed. So this is our agenda for today. I can't tell if the dean has joined yet. Oh, she has. Perfect timing. So we'll have some opening remarks from the Dean of the College of Public Health, and then we will have a series of 3 panelists to discuss frameworks for understanding for this intersection between reproductive health and substance use disorder. And then a quick data overview, and then a session on policy and policy implications. So the frameworks for understanding and the policy sessions have built-in Q&A sessions, and we will save time for that. But Dr. Conrey's presentation on data, she will field questions as she moves along. And then we'll have a closing. And if there are any more questions at the closing, we can have more time for a discussion. So now I will stop sharing my screen, and if Dr. Fairchild has any slides she would like to share, she will take over and give opening remarks.
Thank you, Anne. Can everybody hear me?
Yes.
Okay, I've had a little bit of trouble getting in this morning, so I'm in kind of a weird fashion, but it seems to be working. So I don't have any slides to share, and I will keep things short, other than to say welcome to everybody. I'm pleased to see you all virtually, and this is a timely topic. It's one in which our communities of color are facing a kind of triple whammy in the context of COVID-19. African-American, Hispanic communities have been more likely to have jobs that put people at risk, less likely to have paid sick leave, and more likely, at least twice as likely, to suffer severe health outcomes from COVID-19, including death. And of course, this is a triple whammy in the context of COVID-19, but it's compounded in so many other areas, and it really begins to underscore what we mean when we talk about racism as a public health crisis. Our choices are structured in ways that are very difficult to see. The challenge before us is not just to eliminate disparities, not just to mitigate differences, but to change the underlying social and economic condition that give rise to those choices in the first place, with the lack of choices in the first place. And so, you're here today to talk about the unintended drug overdose epidemic and the ways that in which it intersects with infant mortality, that are another layer added on top of to the layers that we're already struggling with as a local, state, national, and global community. And what lies at the heart of all of our different public health crises are not only forms of structural violence, structural racism, structural discrimination, but also in this case, lack of access to reproductive health care for women with substance use disorders. And I think you're here because that you know a lot of these data, but Ohio, but sometimes it's worth repeating things, because we have to repeat things to policy communities, to advocacy communities, so that our message is a shared one. Ohio ranks amongst the top 10 states with the highest infant mortality in the nation, with a rate of 6.9 deaths per 100,000 live births. There are an estimated nearly more than 700,000 adults, about 8% of the population in Ohio, with substance use disorder. And in 2018, there were nearly 4,000 unintended deaths from drug overdoses. And opioids were involved in nearly 70% of those deaths. At the same time, we have neonatal abstinence or neonatal opioid withdrawal syndrome as a downstream indicator of maternal and infant health related to substance use, misuse, and addiction. And the rates in Ohio are substantially higher than they are nationally. Ohio is leading, but not in ways which we want to lead, and in ways which we need to be leading, and certainly in ways that we are determined collectively to change. The preteen birth rate in Ohio is 49% higher for Black infants compared to white infants. And there is a significant racial disparity in infant mortality among non-Hispanic white infants. And again, these are the result of history, the result of choices, some explicit, some implicit. And one of the things we need to do as a community is not only address the data and these statistics, but think about, come to grips with the history that has brought us to this moment in time. There is a perception, and I think we've seen some of this in the news lately, how data can be perceived. There is a perception of higher rates of opioid deaths amongst whites, but Black non-Hispanic men have had the highest overdose rate in Ohio in 2017. And what we have to do as a community is make sure that whether we're talking about overdose deaths, whether we're talking about police brutality, that we are ensuring that those accurate numbers are reflected in our national conversations. There's a notable disparity in overdose mortality rates associated with adulterated cocaine between Black women and white women. And from a policy perspective, to give you just one example before I hand it back over of policy inequities, there are substantial inequities in access to methadone that run along racial lines. And so this brings me back to where I began. We are now coping with the burdens of COVID-19. We are in a place where we have not all been in this together. in which we must be all in this together. And the work that you are here to do in learning and educating and in carrying forth our values and principles and mission could not be more timely. It could not be more important. So with that, Anne, I'm going to hand it back to you.
Thank you, Dean Fairchild. So we'll just get started and go through our first panel. And Mishka, I'm ready for you whenever you are.
Great. Hello, everybody. Thank you so much for inviting me to be part of this and giving me the opportunity to speak and to sort of start things off. It's I'm really honored to be part of this and with the all the other wonderful people who are on this. My name is Mishka Terplan. I'm trained as an obstetrician gynecologist. I'm also boarded in addiction medicine, and really my work is at the intersections of reproductive and behavioral health. When we talk about the intersections between reproductive and behavioral health, like many times, like the narrative begins really with Margaret Sanger opening up the first birth control clinic in New York in 1916, in violation actually of the Comstock laws, which made contraception illegal at that time. But it's a couple of things to note. One is that this is part of the so-called first wave of feminism, which was associated with suffrage, i.e. women getting the right to vote. And that movement emerged out of the anti-slavery, slavery abolition movement. And both movements, both slavery abolition and women's suffrage, were actually linked to the temperance movement, i.e. to what became the prohibition of alcohol. So from the get-go, these domains of race, reproduction, and substance are interrelated. Now, this narrative of Margaret Sanger is complicated, and is complicated in part by her allegiance, whether, to eugenics movements at that period of time. And I'm not going to get into it, but Dorothy Roberts in this incredible book, Killing the Black Body, really speaks to it nicely. And she talks about how, the language of eugenics, did more than legitimate birth control. It defined the purpose of birth control, shaping the meaning of reproductive freedom. Birth control became a means of controlling a population rather than a means of increasing women's reproductive autonomy. Birth control in America was defined from the movement's inception in terms of race and could never be properly understood apart from race again. And in this book, she has a narrative arc that goes from slavery and from how people who owned enslaved peoples would profit off of the reproduction of Black enslaved women, to contemporary movements where contraception is applied to certain populations, including Black women, as a way of reducing the cost of public welfare agencies. Both of those being injurious, both of those being unjust, both of those being in violation of autonomy. So today, when we think about adding then drugs and drug use to this, there's no end of examples where people's, liberty has been violated, and where legal clauses where people are being sort of coerced into sterilization, both men, but mostly women, in order to, maintain child custody, complete a prison sentence, and etc. And really these are narratives of sort of deserving versus undeserving motherhood, that certain populations of people are less, supported in reproduction. And throughout all of this, there's, you can see like the corrupting influence, of racism in this line of reasoning. So we think of reproductive health as a human right, the right to determine whether and when to have children. And it took a long time to get to. In fact, it took 100 years following the opening of Margaret Sanger's clinic. Until 1959, the NIH was forbidden to support research related to contraception. The term gender equity enters into in 1995. Family planning hardly really gets mentioned until like the 2016 Millennial Developmental Goals. And this is to say nothing of really like a global attention to the relationship between race and reproduction in a specific context. So when we punish certain people, for using drugs while pregnant, for, et cetera, there's a connection between dehumanizing the individual and, the subordination of a group. This is a quote from Dorothy Roberts. And she talks about sort of confronting this through what she terms reproductive freedom. And it's freedom, it's grounded, and this is the framework, being both liberty and equality. So liberty, that is like individual, that's autonomy, that's human rights. That's been the focus of, for example, the UN and those statements. But equally important is equality. And this is the space of government, this is the space of policy, and this is really the domain of social justice. And in this, part of how one does this work is, putting race center in the discussion of reproductive health and substance use. So there's a movement called reproductive justice that emerges from the work of Black women activists who, true to the spirit of Dorothy Roberts, that this is both about liberty and about equality. And if people aren't familiar with the writings, or this briefing book is an incredible collection, of essays that speak to this work directly. So when we think about this topic, really this is, we talk about there's the domain of reproductive health, there's the domain of substance use, misuse, and addiction, and we want to bring them into alignment with each other. But this needs to be done through the lens of race, and in particularly towards the goal of racial equality. And then, so how does this relate to addiction and the addiction life course? When we think, the goal, I spend most of my time clinically doing addiction medicine, and the goal of treatment isn't more treatment. The goal of treatment is recovery. And what is recovery? This is the SAMHSA definition here. It's about integrity, connection to others, purpose, serenity. Sexual and reproductive health are central to recovery. Another way of thinking about recovery is like the inverse of addiction. Recovery is freedom. And so what I want to kind of like here, launching into everybody else's conversations, I want to think about liberty and equality in both reproductive health and in recovery. And that means a framework that's grounded in both human rights and social justice, and that really centers the most vulnerable in our conversations, in our public health work, and in that which we do. And with that, I'm going to stop. And I'm going to pass on the slides to the next person.
Yes, Keitra is up. Go ahead, Keitra.
Thank you. Let me just share my screen here. Great. So good afternoon. Thank you all so much for being here. As mentioned, my name is Keitra Thompson. I'm a family nurse practitioner and second-year postdoctoral fellow at the VA and the National Clinician Scholars Program at Yale School of Medicine. Today, I'll be focusing my presentation on the promotion of equitable family well-being for women with substance use disorders. Because as we know, just like all of us, women with substance use disorders exist in a familial or relational context, whether it be the family from which they came or the families that they have created or in the process of trying to create. I do want to start by extending my sincere gratitude to Ohio State and the organizers of this very important and timely webinar series, and also thank Dr. Terplan for really opening up this session with the strong grounding in autonomy and how holistic care innovations have to recognize the role of autonomy in recovery. And just in case it doesn't become blatantly obvious throughout my presentation today, I do have to mention that the contents of this presentation are mine alone. They do not represent the views of the U.S. Department of Veteran Affairs or the United States government. So as we seek to set the stage and make the case for the important role of reproductive health equity in the lives of women with substance use disorders, I really think it's essential to include the voices of those most deeply impacted by the far-reaching inequities that we have covered. As we start to think about what it really means to promote equitable family well-being for women with a past or present substance use disorder, I ask that you center both your heart and your mind on the words of one of my former research participants. She's a 29-year-old mother of 3 who was enrolled in a family drug court in Baltimore, Maryland. When I asked her to describe the effect that substance use has had on her life, particularly in relation to motherhood, she noted, "Getting my kids back is the hardest thing I've ever done. I've never worked so hard in my life, and I had to do it all by myself. Looking back, I realized that's probably why I started using in the first place and lost my kids and I truly had support. My mother wasn't even there for me. So being young with 3 kids and trying to get through life by myself was a lot. I just wanted to escape. I tried to do things right, but was very I lost a kid. I'm off the drugs has changed my life. I have still no support. Words become often the conversations around action of reproductive health, particularly as it concerns pregnant or parent women. This underlying tension of persecutory shame and judgment. This often places blame on the individual.
Sorry, this is Anne. Your audio is going in and out, so maybe just turn off your video to see if it gets better.
Thank you, Anne. So we think about women that have substance use disorders and then are parenting or pregnant, blame on the individual factors. It fails to call into question systemic oppression, structural inequities, and personal life experience that play a key role in not only the development of substance disorder, but also in how they lack support even after recovery. I'm not sure if I'm frozen. I'm not able to move my slides forward here.
We can still hear you, but it's still going in and out. So I'll let you know if it's worse.
Okay.
Okay.
So as we face the facts, we know that racial and socioeconomic disparities exist within substance use disorder, as has already been mentioned today. That little substance disorders are at increased health and legal risk. Access and utilization is very common among women impacted by substance use, and they have an unmet contraceptive need and desire. Poverty and poor family functioning are both risk factors and outcomes of substance use disorder, really pointing to the role of trauma and the cycle of addiction. 86% of pregnancies amongst substance-dependent women are unplanned. That's compared to, about 47% in the general population, so large disparity there. And that parental substance use is a factor in about 50 to 79% of child welfare cases. So this brings us to reproductive justice, as Dr. Terplan briefly mentioned. And reproductive justice is really at the heart of equitable family well-being for women with substance use disorders. Defined by Sister Song in 1994, reproductive justice is the human right to maintain personal bodily autonomy, have children, not have children, and to be able to parent the children that we have in safe and sustainable communities. It calls us to analyze power systems, address intersecting oppressions, center the most marginalized, and join together across issues and identities. And while reproductive justice is applicable to all people, it was and continues to specifically speak to experience the needs of marginalized communities and communities of color. Reproductive justice moves beyond reproductive rights and issues of access to care, and it really highlights the intersectionality of economic oppression, environmental justice, structural violence, discrimination, and so much more. It is particularly relevant to our conversation today, and it's important to use the reproductive justice lens so that we not only think about pregnancy prevention and prenatal care innovations for substance-using women, but that we also consider the continued care needs and supports that women need even throughout recovery. So where we really think about social determinants of health and the role they play and the inequities faced by women, and certainly, but also in substance use disorder. We have pervasive inequities that really call for comprehensive attention. And I hope that as we think about this, we think about it not only from a healthcare perspective, but in every domain where these exist, they become risk factors, barriers to care with substance use disorders. In terms of thinking about key recommendations and considerations, I think that we must emphasize the role of screening, but screening must be person-centered and equitable. So what that means is that we should seek to screen everyone and not judge a book by its cover, but we also need to make sure the way in which we screen is appropriate and person-centered to the individual sitting in front of us. Comprehensive screening should be done and leads to improved health outcomes. So it's not only about screening in places of reproductive health care, but also screening in substance use recovery organizations. We need increased access to contraception, but it should also be matched with more opportunities for reproductive health education. And then research, policy, and practice needs to recognize the role of reproductive justice across the lifespan, particularly for women with substance use disorders. And then interventions need to address individual, family, and community level trauma. So in summing this up, I think that we all know that person-centered approaches to care are really important in both medical and non-medical settings for women with substance use disorders. But I urge you to consider the need to address the crucial role of access, justice, and desire. What this looks like can be different in different settings. But I think what's essential and core is that we must encourage decision-making and self-efficacy amongst these women, recognize the complexity in their lives, and resist our concept of a right decision by validating their lived experience and supporting safe autonomy. As I conclude, I want to highlight the reproductive justice framework once more, and I want to also bring our attention around this issue of supporting and creating safety nets for women, not only at the prenatal period or during pregnancy, but also through recovery. To emphasize this point, I will end the same way I started, leaving you with the words of someone directly impacted. She mentioned, "We worked hard to get our kids back. We want to keep them. I may have my issues, but I never abused my kids. I really was abusing myself. And losing my kids only made me feel worse and use more. I want to be a great mom. I just don't know where to start sometimes. It is really hard when the kids are running all over the place and my patience gets thin because of my own mental health issues. I just want to be what they need so they don't turn out like me. I want to be better than my parents." So as we think about issues of health equity for these women, I hope that we think holistically and how we can support and encourage them and partner with them to reach their goals through parenting and in life in general. Thank you.
Thank you, Keitra. We're so sorry about the challenges with the sound during Keitra's talk, but like I said before, slides will be available and you can contact me or any of the speakers if you have questions, or you can ask questions later on as well. And now I will turn it to Mackenzie.
Great, thank you so much. Thank you so much for inviting me to be in this space. Thank you both to you, Keitra and Mishka, for your really important messages, and I feel very honored to go after both of you. So as mentioned, my name is Mackenzie Piper, and I work as a senior manager at Power to Decide. Power to Decide is a national nonprofit that works in the space of sexual and reproductive health, and specifically with the lens of access. So in recent years, we've had the opportunity to integrate our programming into some substance use recovery programs. Most specifically, we have worked to integrate our pregnancy desire screening tool called One Key Question into these recovery settings. So My plan over the next few minutes is really just to articulate some of our learnings working at this intersection and to make the case for why family planning services, sexual and reproductive health services should be integrated into substance use recovery settings. All right, so to begin, I think it's really important to center ourselves around the desired goal. And Mishka and Keitra named this beautifully, but it's really that all people, regardless of their gender, age, sexuality, zip code, whether they're using substances or not, can really truly experience reproductive well-being, which is just an extension of reproductive health. To name this really means that a person has the information, services, and support they need to have control over their own bodies, autonomy over their own bodies, and to make their own decisions related to sexuality and reproduction throughout their life. So what does this look like in practice? For one, it means that people have the freedom and safety to experience sexuality as they want to experience it, as long as it is consensual and does not harm others. They have the power to make their own decisions about if, when, and under what circumstances to have a child or not. Two, that people receive access to all information and options available so that they can make informed decisions. They can create a healthy future for themselves and a healthy start for the next generation if they choose to have or raise children. Three, that people are trusted by their providers and met where they are. So their experiences, cultures, desires are respected. They receive information without judgment or coercion from providers who recognize there's no right or wrong answer to complex decisions. And four, just that their well-being and their reproductive well-being, their reproductive health, rights, justice is essential to their overall health and well-being. And it's not only accepted in the healthcare system, but society in general. That these concepts are understood and discussed openly and pursued by all. So if we know this to be our desired reality, I think it's really important then to talk about what specific and unique barriers exist for women with substance use disorders that do keep them from experiencing holistic reproductive well-being across their life course. To really visualize these barriers, we can use the social ecological model, which shows the intersection of these barriers, everything from individual, interpersonal, organizational, community, and societal. As a part of my role, I have trained substance use disorder counselors and case managers on how to integrate family planning counseling and care into their care settings or their recovery settings. So at these trainings, we go through this exercise of naming barriers that their clients face at the different levels in this model. And these are among some of the most prominent challenges that they name. One, that their clients face systemic racism and intergenerational trauma that impacts their access on every level. Two, the majority of their clients are court-ordered to attend their program, and many have open cases with the Department of Family Services, meaning many are currently separated or trying to be reunited with their children. That can add another level of trauma and decision-making around family planning and talking about sexual and reproductive health. Three, their clients experience stigma from society and the healthcare system about their substance use disorder, and more specifically about their pregnancy desires overlaid with that. So as Mishka talked about, there's judgment on who can be a parent, who can be pregnant, and who can't. And four, many of their clients have little to no sex education, so there's a limited understanding of bodies, of pregnancy, menstruation, birth control, how to access it, and how to use it. And I think what much of this leads to is clients not seeking care or not having access to the whole sexual and reproductive health services. So if women with substance use disorders are not experiencing holistic health due to these confounding factors, the following outcomes may not be surprising. And Keitra talked about a few of these. Our data is limited, but what we do know from research is that opioid abusing women do experience unintended pregnancies at much higher rates than other women. We also know that women using drugs are less likely to use birth control, and that may be due to a belief that they cannot get pregnant, and they're more ambivalent about pregnancy. Additionally, substance use during pregnancy can also contribute to downstream problems such as prematurity, low birth weight, inadequate care before pregnancy, neurobehavioral impacts on the child themselves. So knowing this, let's look at why sexual and reproductive health is important in substance use recovery programs. This look at barriers and outcome lead us to ask the question, how could we become more proactive and less reactive in the way we counsel and care for women with substance use disorders, and specifically around their sexual and reproductive health? I think one of those entry points is actually integrating these services into recovery programs. Whether it's outpatient or residential programs, usually they have a very clear goal of prioritizing sobriety, but also recovery freedom, as Mishka talked about. Often this mission is client-centered in nature and really aims to treat the whole client, to promote health, and to empower these people with new skills and new beginnings. These also happen to be the goals of sexual and reproductive health when done right. So we know that for clients to experience whole health, whole well-being, this involves all parts of them, including their sexual and reproductive health. So specifically speaking to the work at Power to Decide, here is what we've done at clinical and non-clinical sites across the county, including a few recovery sites in Arizona, Baltimore, and LA County. So we have implemented a pregnancy desire screening tool called One Key Question. And so as we've seen oftentimes within the first week of intake, every person of reproductive age who can become pregnant is asked, would you like to become pregnant in the next year? They're given 4 answer options, yes, no, unsure, okay, either way. So this is not a binary screening question in nature. It allows for ambivalence. In our day-long trainings, we train SUD counselors and staff how to offer coercive-free counseling sessions with each client, and really based on their individual answer to that question. We provide them with follow-up questions and skills to have a conversation. Most importantly, providers are trained how to connect clients to care. So what that means is a client might need prenatal care, preconception care, contraception care, and that's all according to how they answer that question. This screening question is revisited consistently throughout their treatment plan. We know that for any person, pregnancy desires do change over time. So asking this question with consistency is helpful to track what care is needed. In sites like the one in Arizona, the recovery program is actually attached to a clinic. So full reproductive health services can be offered on site, which is most ideal. For sites like those in LA that did not have clinics on site, they created more robust referral networks. They also had the Department of Health Services co-located at their sites for additional support, such as care coordinators or health educators to support the staff and connect clients to services. As mentioned on the last slide, these conversations may be one of the first time a client has been asked by a provider about sexual and reproductive health in this way. So it's important to have established relationships with the counselors so that can lend to trust around these conversations. I think ultimately we train substance use counselors and staff to be an open door to these conversations, and we train providers of all types, whether WIC providers, home visitors, nurse practitioners, to be an open door for these conversations around sexual and reproductive health. And that does not mean that they're trained to be experts on these topics, but trained to be able to connect clients to care and ensure that their well-being is addressed while they're in recovery programs. So in closing, I just want to bring to light some recommendations, and I do want to credit Keitra Thompson, one of our earlier presenters, and Karen Martineau, who's also on this call, for these recommendations. Both of them have been working at the intersection of reproductive health and substance use recovery and have named some really important takeaways from their work that I am in complete agreement with. Perhaps the most prominent recommendation is to proactively integrate or co-locate family planning counseling and care into substance use recovery sites. Traditionally, these sectors have been siloed in how they provide care, but if we are really tackling health disparities and if those are truly to be addressed, then it must happen that these are working together. So within that recommendation, it's recommended that recovery sites use screening tools to improve care, to build self-efficacy, that providers are using a trauma-informed approach in their counseling and care, and that with increased access, it must be matched with increased health education. But also just that more broadly in research and policy that we are talking about reproductive health, justice, rights, and well-being. So on that note, I want to thank you again for listening in, and I'm leaving my contact information here if you have any further questions. I'll pass this back to Anne.
Thank you, everyone. So we don't have any questions in the queue right now. And we have another 7 minutes until the end of this session. So I would like to encourage attendees to either type in questions in the chat or the Q&A box. But I guess I have one very practical question. Speaking of those silos, I know that funding silos are very challenging as well. So to our panelists so far, like what are some of the typical sources of funding that you and or your partners have access to support these new initiatives?
I'm turning my video back on for this part.
Thank you.
So I've worked on projects that have, so thinking really outside of federal and NIH, although there's been more interest certainly recently, but historically stuff that's been funded either through foundations or through local public health, you know, at the really city county level. There's increased interest at state level, and there have been through HRSA some funding mechanisms, but I would completely agree that historically, you know, the worlds of reproductive health have been separated, you know, from the worlds of behavioral health in general and substance use disorder in particular.
Mackenzie or Keitra, do you have anything to add? I might have a follow-up.
No, I would have to agree with that. I think that particularly when you're looking at kind of like the bottom line and outcomes, and that is really a dollar around doing such work. So I have to
Yeah, and I can speak to our work a little bit. The short answer is that a lot of that funding comes from foundations. And again, a majority of our work is looking through the lens of access. So we're very specifically working in sexual and reproductive health, but just have had opportunities in the last few years to also integrate that in substance use recovery programs.
Great. And I know that our subsequent sessions will have more programmatic information, but I think now that we're starting to think about all of the different frameworks and concepts that you've brought up, it might be a good time to start thinking about these things early. I have 2 questions. So did the women feel it was invasive or that it was none of your business, or were they skeptical about Big Brother knowing their business? I think this is about screening. If the participant could clarify, that would be helpful, but that's one question.
Yeah, I can speak to that a little bit if it was specifically about screening. So I think some of our reflections and our experiences, we talk a lot to substance use counselors and other folks that we're training about the need to build trust, right, and trust over time. And I think we also talk about how, there's so many screening questions that are asked of people, especially when they enter recovery programs, that can bring up a lot for folks in one way or another. So how do you turn a traditional binary screening question into a conversation that can lead to trust and can lead to actual further counseling, follow-up questions that allow someone to feel heard and respected, and then also connect them to care afterwards. So in many ways, that's moving from a binary screening question that's often on, an intake form, to bring that to life and to build that into a conversation that's brought up several times over during their recovery program.
Okay.
And I would just
Go ahead.
add to that's both from the screening as well as like whatever happens subsequent to the screening, like and really like the principles of person-centered care apply here, apply as they would in any clinical context, and that is this is where I think sometimes I like to foreground any kind of screening with asking permission. Is it okay if I ask you some questions about reproductive health? Is it okay I ask you some questions about drinking, smoking, and other drugs? So asking permission and respecting what somebody says. I think that's how we sort of operationalize like a therapeutic alliance, or that's a first step towards it. And so yeah, people should also and this is where the training of the staff, which a power to decide and does on how to ask respectfully, how to center the person that you're sitting across from in the clinical moment.
Karen, I'm going to move on to some more questions, and then you can give some remarks if we have time, because I have additional questions at the end.
Okay.
So what are your recommendations on integrating reproductive advocacy in harm reduction services? I'm going to give that to Mackenzie.
Do you mind asking that one more time, Anne?
What are your recommendations on integrating reproductive advocacy in harm reduction services? And later on in the session, we will have someone from Harm Reduction Coalition. But if any of you could speak to working with any harm reduction partners.
Yeah, I can pass this to Mishka. I can't speak as directly to that, so happy to have someone else take the mic for that one.
Yeah, so maybe it was about, it's probably been over 10 years ago, we integrated reproductive health, broadly speaking, into syringe exchange services in Baltimore City, looking at, the provision of, pregnancy testing parallel to STI testing, and brought slowly like contraceptive options, like literally on the van that did syringe exchange services. There are now, since then, there's I can count on one hand, other, syringe exchange programs that have attempted to integrate some form of reproductive health. Some have been more successful than others. But I do think really what Keitra was saying about thinking about not being, when we think about reproductive health, this isn't just pregnancy, this is like the life course, and thinking about all the different places where people, come into contact with healthcare systems and breaking down those silos. So that means, it means bringing reproductive health into harm reduction, services, certainly.
I think even when, services aren't co-located in that way, or specifically harm reduction, with still using that framework and how you're approaching, the conversations around reproductive health and around the substance use disorder. And I think that's really where, it comes in terms of women that, already have children are going through recovery, and how to support, their decision-making and their autonomy, even though they may be using substances and still desire to parent.
I have a kind of connected question. At what phase of treatment do you find counseling on contraception to be received well? sometimes clients come in with many different potentially life-threatening issues. So when do you find people are ready for this conversation?
I mean, I don't think there's a monolithic answer to that. I know when I had a pilot project integrating the one key question and integrated services into pilot drug-free treatment programs in Baltimore, you know, two things happened. One, actually all the programs wanted to expand the screening to be inclusive of men and non-gender binary people too. So to ask everyone about, you know, a partner pregnancy, themselves pregnancy, parenting and stuff like that. And then the second thing was, you know, like how often you know, like, should it be like, you know, that first day where you get a, like, you know, like you've got 2 hours of screening instruments, or should it be later on, or, you know, like, how do you follow up? I mean, I think I'm not trying to dodge the question, but I really think it's like the people who work locally, you know, are, you know, going to, and it's not just the screening, it's also like, there's other ways to communicate information, you know, through like, you know, printed stuff. I think it's really important, and this is, you know, what the people do this, like to have, you know, integrating into, you know, the group format of behavioral health, something about sexual and reproductive health. So there's a lot of ways, you know, to kind of offer people the opportunity to, you know, to ask questions if they have them. It's not just about screening and a screening instrument. It's about a welcoming, holistic environment of care that centers on the person.
Yes, so I have one more question to that. And it's about integration. Do you think it's better to have SUD services at reproductive health locations or reproductive health services at SUD locations? And in my mind, this question is really interesting because adolescent substance use is also the same time for sexual initiation. So I've always thought about primary care and family practice as the initial place for someone to experience both of these conversations and both aspects of their individual self. So if you could speak to that, and then we'll move on to the next session.
I would have to say that I can't say that, you know, there's one way to do it that's like more important or better than the other. I think that, you know, right now it's, you know, screening for substance use disorder in healthcare or, you know, reproductive health settings is, I think, a little bit more common than integrating or the provision of reproductive health services and recovery programs. So I think that really they should be in both places. I think that right now a lot of the emphasis has been on trying to integrate reproductive health services into substance use facilities or recovery programs because it just has been lacking for so often. And those are the individuals that often aren't seeking primary care or healthcare services due to many of the issues that people outline, stigma and all of that. So,
Mishka, do you have anything to add?
I mean, I just echo that, and I'd say the answer is sort of both. And if we believe in integrated care, and if we believe in like holistic, you know, person-centered care, that means that, you know, that's not just in the space of recovery. That's like, you know, that's you know, kind of everywhere. The issues that emerge are different, though. You know, when you're talking about a reproductive health, like a Title X clinic, most of those people, you know, actually don't have addiction. Whereas everybody in drug treatment, you know, has a use disorder, and then you know, in the intersection you discussed, which was between sort of you know, pregnancy and substance use in, you know, an adolescent population, you know, so there's unique things emerge, you know, around the different types of integration in those spaces. But I think it needs to be bidirectional, and even if you're not like, so the integration doesn't mean that you build a drug treatment clinic within a Title X, although there's some examples of, you know, buprenorphine prescribing within those spaces. It means like, you know, creating connections and for transitions between, you know, different programs and really creating a local ecosystem that where, you know, both substance use and behavioral health are addressed and, you know, access is provided.
Fantastic, thank you. I know that there was a question that we didn't get to, but if that participant can put it in the chat, I would like to ask the panelists to kind of go through the chat and answer any questions that come up because we're running out of time. So I'm gonna let Dr. Conrey begin her presentation. I will mute myself.
Thank you, Anne, and I will share my screen. Okay. Just a sec. Okay. So thanks to the presenters so far and the organizers for putting together such an important topic for us to share today and learn from one another about. Good afternoon. My name is Elizabeth Conrey. I'm a senior maternal and child health epidemiologist at the Centers for Disease Control and Prevention in the Division of Reproductive Health. And in that role, I'm assigned to work with the Ohio Department of Health. Today, I'll be sharing an overview of the epidemiology of substance use disorder and overdose among women of reproductive age, as well as neonatal abstinence syndrome, with a focus on Ohio. Just to give some context before I start with my slides though, as was mentioned earlier, just about half of all pregnancies in the US and in Ohio are unintended, meaning that the woman who became pregnant did not wish to be pregnant at all or at that time. In fact, about 5% of women of reproductive age have an unintended pregnancy every year. Unintended pregnancy rates are highest among low-income women, women who are cohabitating, and women of color. Specifically, the rate of unintended pregnancy among non-Hispanic Black women is double the rate of non-Hispanic white women. And education is also associated. Women with a high school degree had the highest level of unintended pregnancy. About 1 in 10 women of reproductive age in Ohio also are uninsured, and that rate is higher in most states that have not expanded Medicaid. And about 2 in 10 have not seen a healthcare provider in the last year. So this just provides some context to this group of women of reproductive age and what's happening with their health and healthcare and their desires for pregnancy and their experiences with pregnancy. And these same group of these women are also experiencing substance use disorder. The findings and conclusions in this report are those of me, they're mine, and do not necessarily represent the official position of the Centers for Disease Control and Prevention. In the United States in 2018, the rate of unintended drug overdose death was 20.7 per 100,000 population. And the range among states varied from 6.9 in South Dakota to 51.5 in West Virginia. Ohio had the 5th highest death rate among all the states. Now I'm going to focus on unintentional drug overdose deaths just among women of reproductive age. This figure shows the number in that line and the rate in the red bars of unintended overdose deaths from 2008 through 2013 for women of reproductive age. Following trends in the general population, deaths among women aged 15 to 44 began to rise sharply after about 2013, and that rise didn't let up until 2018. Now this figure breaks out that trend in deaths from 2013 to 18 by age ranges of women of reproductive age. And we can see at the top in the red and gray lines that the older women of reproductive age, 25 to 34 and 35 to 44 years, had the highest death rates. while younger women, shown in that lower line in orange, experienced the same trend, but many times fewer deaths. Looking at specific groups of substances, this figure displays the number of deaths in 2017 in light red and 2018 in dark red. And note here that the numbers aren't mutually exclusive because more than one substance can be implicated in a woman's death. Here we see that fentanyl was the most common substance, followed by cocaine and heroin, and psychostimulants were the only substance with an increase in deaths from 2017 to 18. And this is for Ohio. Here, looking at just 2018, the most recent year of data that we have available that are complete, the group of bars on the left represent Black women and in the middle, white women. For women who are 25 to 34 and 35 to 44 years, those are the gray and yellow bars, we see that mortality is greater among white women compared to Black women. However, among the youngest women represented in orange, there's really virtually, there's little difference in the rates of unintended drug overdose between Black and white women. This trend in overdose deaths by race is even more telling and concerning. At the top in green are white women of reproductive age, and we see that same trend that I showed earlier with a sharp increase from 2013 to 2017, and then a small improvement in 2018. However, among Black women, shown in blue, looking at the solid bar for women of reproductive age, there's no improvement in 2018, but rather we see a continued increase. So whatever is happening in our society to stem overdose deaths among women did not reach Black women in the same way that reached and saved Black women. White women did not reach Black women as the same as white women. Now let's talk a little bit about hospital discharges and neonatal abstinence syndrome. This slide shows the number of Ohio newborns who were discharged from hospital with a neonatal abstinence syndrome diagnosis from 2006 to 2018. Compared with deaths among women, we see that the increase in NAS diagnosis was more gradual and steady over time and started to abate a little bit earlier in 2017 rather than 2018. Of note, the neonatal abstinence syndrome diagnoses among infants insured by Medicaid, shown in the darker yellow portion of the bars, accounted for the vast majority of all NAS cases. So most women delivering infants and infants born with who have an NAS diagnosis are insured by Medicaid. These data focus on the mothers and show the number of delivery hospitalizations with drug abuse or dependence diagnoses, and broken out by 3 specific substances, again from 2006 to 2018. And here in that darker yellow bar at the top, we see that marijuana is most often identified as a drug associated with drug dependence. The number during pregnancy, and that number of diagnosed marijuana dependents increased steadily over time, over this time period. Cocaine, shown in gray, decreased after 2006, but has seen a bit of a resurgence in more recent years. And opioids increased pretty steadily from 2006 to 2016 before tapering slightly. Now, finally, I want to share some data on pregnancy-associated mortality and substance use disorder. Pregnancy-associated mortality. So pregnancy-associated deaths in Ohio have been reviewed by Ohio's Pregnancy-Associated Mortality Review, or PAMR, since 2008. And at this point in time, most states do have a maternal mortality review. Pregnancy-associated deaths are deaths that are temporally related to pregnancy. These are deaths that occurred during pregnancy or within 1 year of the completion of a pregnancy, but regardless of the cause of that death. Again, just some of these deaths, a subset of these deaths are causally related to pregnancy, but some of them just happen to occur at the same time of a pregnancy or within a year postpartum. Last year, the Ohio Department of Health put out its first comprehensive report of pregnancy-associated deaths that occurred during 2008 to 2016. I'll share some of those data. Out of a total of 610 pregnancy-associated deaths identified, 116, 19%, or about 1 in 5, were due to unintentional overdoses. So these actually, most of those occurred in 2015 and 16. We found that the trend in pregnancy-associated deaths mirrored the trend in deaths among all women of reproductive age. That gray line at the top is basically what I showed earlier, but only until 2016. And the lower red line shows only deaths that occurred during pregnancy or within a year after pregnancy. The numbers are smaller, but the trend is the same. Let's focus now on just that lower red line and break it out by substance. While prescription opioids, at red on the bottom, stayed relatively flat, heroin deaths increased after 2011, and cocaine increased along with fentanyl after 2013, with fentanyl in that dashed line towards the top, accounting for the greatest number of deaths within a year of pregnancy in 2015 and 16. When do those deaths occur? During pregnancy in the gray part of this circle on the left, fewer than a third of deaths that were due to unintentional overdose occurred. In the early postpartum, so within 42 days after the end of a pregnancy, at the top in light red, only 7% occurred. But most, 2/3 of these deaths to unintentional overdose occurred from 43 days to up to a year postpartum. That's similar to other data in other states have shown the same thing, where most of those deaths occur in the later postpartum period. By race and ethnicity, the overwhelming majority of deaths to women by unintentional overdose were associated to pregnancy that occurred from 2008 to 16 occurred among non-Hispanic white women in the state of Ohio. By some other demographics, deaths were more likely to occur among women living in Appalachian counties, counties part of the Appalachian Mountain region, as well as in metropolitan counties. And we see a very strong association with education, where death rates among women with a high school degree, level of education or less, were twice as likely as women with more education. And of note, these are some of the same associations that we find with unintended pregnancy. So it's some of the same demographic groups who are experiencing higher degrees of pregnancy, of unintentional overdose, are also experiencing pregnancies that they did not desire at that time. And to finish up here, I want to touch on what the Ohio's Multidisciplinary Review Committee determined about these deaths. The committee determined that 45%, so almost half of these unintentional drug overdose deaths, were preventable, meaning that there was at least some chance of the death being averted. The committee also identified factors that contributed to the reviewed pregnancy-associated overdose deaths. And they identified these factors at 3 different levels. The first is at the facility or systems level, shown in the top here. The most commonly identified factors identified were access to care, inadequate continuity of care across providers or across time, inadequate outreach, or inadequate policies and procedures. At the provider level, shown in the middle, the most commonly identified factors were inadequate assessment of the patient, inadequate continuity of care, and lack of referral. And at the individual or family level, the most common factor was substance use, not surprising, but followed by mental health conditions and non-adherence with medical recommendation, not always, well, for many reasons, violence and delay. That's what I have. There's some time for questions, I believe, Anne.
Yes, we don't have any questions yet, but I do have one myself. What can you speak to any initiatives at the State Health Department that are addressing some of these recommendations, or anything else going on among your colleagues at ODH to kind of like stem some of these challenges?
Sure, thank you. The Pregnancy Associated Mortality Review was recently awarded 2 large grants by the federal government. One is more focused on improving surveillance, and the other is focused on action. And actually there's a third small one that's focused on overdose deaths and improving the review of those deaths and the recommendations that come out of them. But with the activity, the state is currently forming a large task force to come together and look at the data and make recommendations and have work groups and act on those recommendations to improve mortality in Ohio. I don't work closely with the reproductive health group at the State Health Department, but I do know that they have initiatives to integrate better care around substance use for women who are seen in Title X reproductive health clinics. There are efforts to increase continuity of care and referrals generally through quality improvement initiatives.
Great, thank you. There was another question in the chat. Why do you think most deaths occur in the postpartum period?
Thank you. Again, this is not an area I'm an expert in the biology. I think Mishka and some of the other presenters could talk much more clearly about this. However, we do know that during pregnancy, many women do reduce their use of substances and have more access to care and treatment and are in regular contact with healthcare and are motivated to reduce their drug use. In the postpartum period, women begin to lose contact with providers and also have increased stress and lower support. There's also some biological reasons that can come to play. A woman who's reduced her drug use during pregnancy, when she relapses, may go back to using an amount that she previously used, and which may result in an overdose. She may also have been using more opioids during pregnancy because her body needed more to have the same effect because of her blood volume and other changes in pregnancy. And if she uses that same amount in the postpartum, she may be more likely to overdose. Would someone else like to tackle that one?
Well, while the other panelists are thinking, I do have one more question for you. Will the task force that you mentioned at ODH include stakeholders with lived experience of substance use during pregnancy?
That is a great question. We are including women who have lived experience of maternal morbidity and families who have lost a woman due to a pregnancy-associated death, I will have to do some checking to see about if there is a woman with a lived experience of substance use. Thank you for that.
Okay. I see Mishka might answer.
Yeah, if you want me to, I'll just speak a little bit. I completely agree with everything about like, why is the postpartum period so vulnerable? And it's because to a large extent, it reflects our programming. We put all of our attention, all of our public health work and dollars to a large extent in the pregnancy box. And there's like, one postpartum visit that's, part of prenatal care. But in many ways, that postpartum period, the so-called fourth trimester, is the most important trimester. There's like, mood changes, there's insurance realignment, Medicaid stopping in states that didn't expand, but even in states that had Medicaid expansion, there's a realignment of somebody's eligibility because suddenly your family unit has changed. So just thinking that expansion is going to fix this is incorrect, actually. And in addition to all those things you said, the only other one that I would add would be child welfare. And loss of custody, kids going into the foster care system, loss of parental rights is a real risk factor for recurrence, and use is a risk factor for overdose and for overdose death. So how we structure care, what we do, and how we actually criminalize substance use and addiction, in particular in pregnancy and in particular for poor women and women of color, that actually contributes directly to the data that you shared.
Thank you.
Yes, I absolutely agree. And if we were to expand this and even think about what's happening in the preconception stages and lack of access there, and thinking about it more holistically and person-centered, I think we will typically come to the same conclusions about systems failures and silos. And this is a great transition into a deeper dive into some policy implications, especially for pregnant women and harm reduction. So I'm gonna let our speaker, Rose, are you going first? Okay, yes. Rose is going first, and then Indra. Thank you.
Thank you. I'm just gonna get my slides up. I know that usually folks are not super excited to hear that after a few hours of presentation, the lawyers are going. So I promise not to have this be sort of traditionally how lawyers generally talk to you, and to make it worth your time and your attention. To be still engaged. I know that sometimes the Zoom life that we lead is a little difficult. But as Anne said, I'm Rose MacKenzie. I'm the Senior Director of Policy and Mobilization at the Harm Reduction Coalition. And for folks who don't know Harm Reduction Coalition, we are a national nonprofit. We have offices in California and New York. And a lot of our work is around capacity building and training for harm reduction programs. So helping folks establish or integrate harm reduction programs or practices into the work that they do. But we also have a policy and advocacy side of what we do. We do some direct advocacy in New York and California where we have offices, and also at the federal level, often at the agency level. And then a lot of our policy and advocacy is about leadership development in communities, to have folks in their own community be advocating for the kind of change they need to see for harm reduction. So that's sort of an overview of Harm Reduction Coalition, but I thought that in order to start this, it would be useful to kind of ground folks in the framework of harm reduction as HRC uses it, which I think is a little bit different than sometimes folks are kind of aware of. So I think a lot of times people have heard something around this last bullet point of meeting people where they're at. I hear a lot of times people use those words, and sometimes people knowing the like meet people where they're at and don't leave them there. And this is sort of the idea that folks are using drugs or engaging in sex work, and that is where they are at right now. And to engage with them, it's not okay to sort of come in and say you have to change what you're doing in this moment in order to be able to have support and services and programs and policies that allow you to live a thriving life. But that instead we sort of accept where people are in the circumstances that they're operating in, get them what they need in the moment, and then hopefully bring them along into whatever it is they need to live a sort of better, more thriving life. I think also folks in sort of a medical field often know sort of this second bullet point that's around the spectrum of strategies that fit into harm reduction. And this is, I hear a lot of times people saying seatbelts are harm reduction, bike helmets are harm reduction. Right now we're talking a lot about voting is harm reduction. Which I have thoughts about if anyone wants to hit me up later. But this is the idea that there's sort of strategies and practices that are harm reduction, which moves people who are engaging in a risky activity into a way of doing it that is less risky, that reduces their harm, right? And in the area specifically around drug use, that's looking at safer drug use strategies, which can be testing your drug supply to make sure that you know what you're taking, using clean syringes and having access to things like that, not using alone and having naloxone around to make sure to manage an overdose. It can be strategies around managed use. There's a large spectrum of drug use between sort of chaotic, harmful use and complete abstinence, right? And so putting in sort of limitations around how you use, when you use, where you use, who you use with can really help folks kind of reduce the harm of drug use. And then all the way to abstinence, right? Not using drugs is certainly a harm reduction strategy. But the thing that I want to point out, and I'll go a little bit more into this in the next few slides as well, is the piece that I think a lot of people are missing when they either know the like meet people where they're at piece or the kind of bike helmets and seatbelts piece, which is that harm reduction as a framework, as a movement, sort of capital H, capital R harm reduction, is a philosophical and political movement focused on shifting power and resources to people most vulnerable to structural violence. Right, so it's not just about the seat belts and the bike helmets and the clean syringes and making sure you have limitations around your use, but it's making sure that we are always striving to move as much as we can the power and resources to the folks who are vulnerable to the harms of drug use to be able to make the choices that they need around their whole lives. And we sort of think of this, we put this in terms of 6 principles of harm reduction, which I'm gonna go through fairly quickly because a lot of times this is really structured for service providers and programs, which I think is really useful. And if there's anyone out there who sort of wants like a harm reduction 101 for providers, we offer a lot of trainings and certainly reach out. But the main focus that I think is really important is that there's a focus on health and dignity, that the quality of your life as both an individual and as a community and the well-being of people in their communities is front and center in doing harm reduction. And it's both front and center in doing harm reduction services, but also in creating sort of policy change and advocacy strategies, right? That what we are really trying to do is to make sure that people are able to live healthy, thriving, beautiful lives, no matter what choices they're making around harm or around drug use, no matter what choices they're making around sex work, and any number of other things. These next 3, and I'm not going to read them out loud, but these next 3 are really about patient-centered, participant-centered. We use the term participant, but often folks use patient. And the involvement of people in their own autonomy, right? And this is what some of my other speakers were talking about as well, right? Making sure that people are agents of change for themselves, right? That everything that is happening is because they want it to be able to happen. The piece around this that's really important to policy is the way we do harm reduction policy. It is all driven by community, right? It is people in their own communities who are facing these issues. So people who use drugs, people who trade sex, coming together to figure out what are the barriers that exist to me living the life that I want to lead, which pieces of that are policy and legal related, and how do we make a strategy to change that gets me what I want. It's all based in sort of this like participant autonomy, participant centered, and you can move that into policy as well, right? That policy change should be community driven and community developed. The last two pieces I think are really important to think about, both in terms of services and in terms of policies. One is the sociocultural factors, right? We have to recognize that things like poverty, racism, sexism, trauma, they all are influencing where people are, how people are able to sort of show up in conversations, in getting the services they need. It influences people's relationship to drugs. Like it says here, I think this is really beautiful that we use, it affects people's vulnerability and capacity for effectively dealing with potential harm. And if we are not creating both services and programs and policies that take that into account and try to push against that, then we're not going to create something that is actually useful for people, because those factors exist and they are pushing on people's lives. And the last is that it's pragmatic and realistic. I think that one thing that I hear sometimes in relation to harm reduction is that folks feel like it's helping people use drugs, it's encouraging drug use, all of that kind of stuff. And harm reduction does not attempt to minimize or ignore the tragic harm and danger associated with drug use, right? But the thing to keep in mind, along with this idea of being patient-centered and participant autonomy, is the fact that it is paternalistic to tell people that they don't understand the harm and danger that they are in, right? As communities come together and figure out what they need, these are the people whose lives are affected by chaotic drug use. These are the people who are losing friends and family to overdose, right? They know that drug use is a harm, right? And so it is not about sort of doing programs or creating policy in a way to encourage that. People are aware of that and we don't minimize it, but we don't have to sort of be paternalistic about how we approach it. So that's kind of the framework of harm reduction. So what does that mean for policy? I realize that this slide is like completely not how you're supposed to do slides, because it has so many more pieces of writing on it. And I'm not going to read the whole thing to you, but I wanted to have this as we share it out. But HRC does our work, all of our work, including our policy advocacy, based in a North Star statement. And the statement's a little bit longer, but the core, the heart of it is that we attempt to heal the harms caused by racialized drug policies. And for advocacy work, what that means is that we empower communities to work in their own community, to work themselves, to repeal the laws and the policies that cause systemic or individual harm to our community of people who use drugs, our community of people who trade sex, their families and the people around them that they love, right? And we replace those harmful policies and laws with laws and policies that facilitate their well-being and the well-being of the community. And so for us, we believe sort of 4 core things that drives our policy work. That everyone deserves access to harm reduction programs and services with dignity in their own communities. That everyone deserves affordable access to the full range of medical care that they desire without stigma or medically unjustified barriers. That people who use drugs and or people who trade sex deserve to live free from increased criminalization and surveillance, and that people who use drugs or trade sex deserve access to social supports, things like housing, healthcare, education, and jobs without discrimination and with dignity. And weave throughout our policy vision, is the understanding that this cannot be achieved without censoring racism, right? We understand that all of these are harms caused by racialized drug policies. And we also understand that to unpack that harm and to really get to a better place, we have to center the needs, particularly of Black folks within our own community. We have to understand how they've been historically underserved, how sort of medical racism and over-policing are playing out, and that the intersectional discrimination that folks face is a piece of what is stopping them from getting what they need. So what does this mean for reproductive health? Again, this has too many words on the slide and I apologize. However, we wanted you to kind of have all of this information and we wanted you to have it in the form of questions. I'm not gonna leave this presentation, I'm not gonna leave you with a list of policies that can sort of solve for reproductive health and drug issues, right? I'm gonna leave you with questions to grapple with. So if you, like me, believe that everyone deserves access to harm reduction programs, there's things to think about in terms of policies. And when I say policies, I mean laws, I mean regulations, I mean institutional policies and practices, and the rules that we use in our programs, right? And so some things to think about are there pathways to harm reduction programs through reproductive health care and vice versa, right? Some of the things that folks were talking about earlier, can you co-locate services? Are there strong referrals? And I would say that part of the policy piece of that is really making sure that they are patient-centered referrals. Not everyone who shows up in reproductive health care who uses drugs wants to be entered into harm reduction programs, and not everyone in a harm reduction program who might have reproductive health needs wants access to that right now. And so people shouldn't automatically be shunted into services because of their identity or because of the things that they're doing, but that all of it should really be patient-centered care and making sure that we are giving people the tools and the resources to get the things that they need. Another big piece of this is our harm reduction programs welcoming to women, trans and gender nonconforming folks, and sex workers. These are populations that have sort of more and increased reproductive health needs. And if the harm reduction programs themselves are not safe spaces and are not welcoming to them, then there's no way that we can be sort of increasing the you know, both substance use harm reduction programs and reproductive health ecosystem. Another thing to think about is are parental rights put in jeopardy by the use of harm reduction services? And Indra, who will speak after me, is going to speak to a lot more specific policies that are sort of historical or in place right now that can affect things like this. But one thing we really need to think about is sort of accessing and using a syringe service program, or is carrying naloxone putting people at risk for losing their parental rights or having other kinds of issues around parenting, and what can we do to either change those laws or to make that safer for folks we are coming into contact with. And again, when we're talking about affordable access to the full range of medical care, we have to think about, is reproductive health care conditioned upon abstinence? Is it conditioned upon agreeing to drug testing? Are we putting in place training and oversight to ensure that there is not discrimination against people who use drugs and people who trade sex, or that there's not coercion into specific reproductive health choices? Folks talked about this a little bit before, but you know, people who use drugs and people who trade sex in general in society are not looked on as people who should be parents. Right, and so there's a lot that pushes people to getting contraception that they may not be interested in, or to making reproductive health choices. I don't know if folks were following, in the last couple of years, there was a case out of Tennessee where there was a judge allowing for reduced sentences for folks who would agree to have a long-acting reversible contraception implanted. And it's things like that where we are really using policy and procedures to push people into reproductive health choices that they might not want because of who they are, because of the things that they do. We also really, in this area, we really need to think about prenatal care is often sort of conditioned upon either abstinence or drug testing, or at least sitting through people telling you you shouldn't be drugs, which you shouldn't do drugs, which a lot of people already know, right? And so it's really important to make sure that you have protocols and institutional policies around drug testing only when it's really medically necessary, sort of building up the relationship in order to really get true informed consent, so that when you are telling people, I need to do this drug test for you and these are the reasons why, that they can trust you and that they can know exactly what it's being used for, and to make sure that no medical care is subject to agreeing to testing, right? That even where it might be medically necessary, if folks aren't not comfortable with that and don't want that, that doesn't mean that they're not able to get the medical care that they need. when we think about increased criminalization and surveillance, I think reproductive healthcare and healthcare in general is a place with a lot of police and CPS, Child Protective Services, involvement in care, right? And so really thinking through which parts of that are really necessary for what you're doing. And I would like to offer that probably it's less than what you're doing right now. And thinking about what are the sort of practices around that. I would say first and foremost, you should always be giving clear information to all of your patients before this comes up on when and where cooperation with CPS and police happens in your services, so that they can make informed choices about when they show up, what they share with you, all of that kind of stuff. And then when we're thinking about access to social supports, a lot of times there's abstinence or drug testing requirements for that. This shows up a lot in intimate partner violence and other kinds of shelters. And when I say abstinence, I often mean abstinence from drugs and abstinence from sex work. And this shows up a lot in shelters, that if you are not willing to say that you will no longer sort of perform sex work, and if you are not willing to say you will no longer do drugs, then you are not welcome in shelters. And that means that for people who use drugs and people who trade sex, they don't have access to services they need to stay safe and healthy. This comes up in other places as well, like drug testing for welfare and all of those kinds of things. So it's really important to talk about what sort of social supports do you offer? What do you have connections with? And what are the barriers specifically to people who use drugs or who trade sex in order to access those supports? And I'm phrasing these all as questions because I think that it's really important to keep in mind that none of these, like not all of these, will be useful for what you're trying to do or useful for where you work, right? You may not work in medical care. You may not work in somewhere that has CPS involvement. You may not work in somewhere that has connection to social support. But wherever you are sort of engaging in the world around you, there is ways that you are creating barriers to access for people who use drugs or fostering better access for people who use drugs. And so it's important to start to sort of think about what is within your sphere of control? What do you have the ability to kind of make changes on, whether that's in advocacy, whether that's in practice, whether that's in medical care, all of that kind of stuff, and really interrogate for yourself in an ongoing way. What are you doing to make that safer and more accessible to people who use drugs and people who trade sex? So I'm going to end it there and pass it over, I guess, back to Anne or over to Indra. I don't know who goes next.
Indra will go next, but I just wanted to thank you for some very practical considerations. That was really helpful. And then we have 18 minutes left. I want Indra, you can take your time. We don't need to do a closing. And if anyone has questions, I'll field them and maybe we can ask them after your presentation. Thank you.
Okay. Well, thanks for hanging in there with us, everyone. I look forward to reinforcing and echoing what my colleagues have said. Thanks for holding this important series and this important webinar today. I'm Indra Lusero, a staff attorney at National Advocates for Pregnant Women. If you are not aware of the work that we do, we basically try to ensure that no one is locked up, shamed, or denied constitutional or human rights due to pregnancy. So I want to talk a little first about the roots of our perinatal healthcare system to the extent that we have one today. We basically have not yet had a system of care that's really well designed for the optimal health of all humans, much less, and especially not, women, people of color, LGBTQ people, poor folks, or disabled folks. So we haven't yet had it, we don't now have it, and there's some reasons that we don't now have it. I want to look specifically at how access to health and life-affirming care today was limited by the stigmatizing, prejudicial, non-scientific, anti-woman, classist, and racist campaigns that informed much of 20th century healthcare and is really the foundation of perinatal healthcare today. So this slide shows both an image from an old newspaper talking about the female abortionist, and you can see it's kind of a scary devilish image there at the bottom. And about the 1850s, a strong campaign was developed to outlaw abortion. And it was really connected with regulating morality around women's roles and sexuality. Here, the quote from Dr. Storer is talking about how if people aren't procreating in marriage, it's basically legalized prostitution. Then we also, Dr. Terplan referenced the Comstock Act of 1873, also critical during this time and really influential in perinatal health care in the 20th century. Categorizing as a matter of law contraception as obscene and illicit. So you take these together, plus in the 1920s, the campaign to eliminate midwifery. And that campaign in particular was specifically about distinguishing white male obstetricians from the women who had up to that point mainly been providing midwifery services. And those were women who were immigrants, who were Black, who were Indigenous, who were of the communities that they were serving. So there's a direct line from those campaigns to the state of affairs today, where we have 87% of counties in the US with no abortion provider, where we have maternal mortality and morbidity rising, along with rising costs and growing inequities. I'm sure many of you know that maternal mortality for Black and Indigenous folks is 3 and 2.5 times higher than for white folks. And this is the context that pregnant folks dealing with substance use exist in. So even without substance use as a factor, this situation is far less than ideal. And of course, the context of today's foster system is similar. It has explicitly classist, racist, xenophobic, ableist roots, starting with the orphan trains in 1854, followed shortly thereafter by the Indian child removals of the 1860s. And there's a quote here from the Supreme Court case of 1927, Buck v. Bell, which is actually still good precedent. This case hasn't been overturned. And you can see it's just deeply tied to really the country's history of eugenics. I think this case kind of represents the culmination of the eugenics movement in this country. It's also interesting to know that aid to dependent children in 1935 identified undeserving impoverished parents, and instead of giving them cash aid, put their children in foster care. For example, widows with children could get cash assistance, but if they were single and unmarried, they could not. That cash assistance was used instead for the foster families. And this trajectory, this history of eugenics, follows into the development of our contemporary drug policy. I think of Harry Anslinger as kind of like the Stephen Miller of his day, and his quote really speaks for itself. I won't read it to you, but it absolutely underscores the connection between racism, between anti-women, very biased approaches to society and drug policy. Of course, this was followed by the Nixon administration. And I want to read to you a quote from John Ehrlichman, who's pictured in the bottom right corner. He was a member of the Nixon administration, and in an interview in 1994, he said, "The Nixon campaign in 1968 and the Nixon White House after that had two enemies, the anti-war left and Black people. And we knew we couldn't make it illegal to be either one of those, but by getting the public to associate hippies with marijuana and blacks with heroin, and then criminalizing both marijuana and heroin, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. So of course, all of this has vast public health consequences. In addition to poor reproductive health care access and outcomes, there's an increase in the prison population across the board. But also, look at these rates of incarceration for women. They rise dramatically in the 80s, and this trend coincides with NAPW's research focusing specifically on pregnant women. NAPW published a report tracking arrests of and forced interventions on pregnant women in the United States from 1973 to 2005. Since then, we've continued tracking cases, finding twice as many cases in half the time span. You can see that represented on this graph here. And actually, before I move on to the next slide, I just want to ground these statistics in one of the many stories that I know from my work of an actual person. Most recently, I've been working on a case in Montana of a woman who is a Native American woman who in December last year, December in Montana, in the middle of the night, was feeling badly enough. She felt weird. She was feeling badly enough that she thought she might have to walk to the emergency room. She heads out, fortunately gets a ride, ends up at the emergency room. She's feeling really bad. She thinks maybe she has kidney stones. She goes to the bathroom in the emergency room, ends up giving birth. She didn't know she was pregnant. Hours before, she had used meth, which she shortly discloses to her care providers, who then report her to the police. She's been charged with criminal child endangerment, both for her giving birth without knowing that she was pregnant and for her substance use during pregnancy, which she was not aware of due to not being aware of her pregnancy. It's a great example, and I see so many of these, of that intersection. She had a lack of access to care. She didn't have, counseling about contraception. She had an unintended pregnancy, and it led to these criminal consequences. Interestingly, in fact, the demographics of those most impacted by these criminal cases has shifted. In the 1973 to 2005 study, the majority of cases were women of color. But recent state-specific studies indicate that a majority of cases are now white women. Kiara Bridges points out in this great article that's referenced here on the slide that the criminalization of substance use during pregnancy exposes both the consequences of the racist roots of these policies and also how white privilege actively produces white disadvantage, underscoring how and why we must take an intersectional and anti-racist approach to reproductive health. Abortion policy, drug policy, and maternal health are all interconnected. Further, in a review of 40 years of state alcohol and pregnancy policies in the USA, the authors question whether these policies were in fact best practices for public health or efforts to restrict women's reproductive rights. They determined that in fact policies targeting alcohol and drug use during pregnancy actually cause harm, not just in terms of child welfare or criminal cases, but in terms of worse maternal health outcomes, like more preterm and low birth weight births. So in terms of specific things that I hope people would consider for women with substance use disorders, screening, even screening testing, and reporting all have consequences. They come with risks that may counteract their potential benefits. So first, in terms of screening and testing, we have to consider what the tools do and how effectively they work. Screening might be helpful if it connects people with treatment and services, but there is a serious lack of access. And if folks can't get access, they could be further punished for being identified and referred, but then not getting care, getting treatment, or being in recovery. Screening happens in the context of this bad system where there are racial disparities and biases and where patient needs are not met. In terms of testing, the clinical benefits are often doubtful, and there's too much room for bias and error, the kind that can really destroy someone's life. And so far, some research has indicated that universal screening doesn't fix the problem, basically because it's happening in this bad system. Pregnant and postpartum women are often drug tested in medical settings without their knowledge, without their explicit informed consent, and this too undermines the doctor-patient relationship as well as violating their human rights. So this graphic is actually from our resource, the Birth Rights resource, which is available online and includes this information and more. And we encourage you to share this with your networks. Of course, I'm happy to answer any more questions about any of this. The existing system, as this headline suggests, is one of illogical priorities and resource waste. For example, if these headlines weren't enough to show that there are problematic financial incentives at play, as well as the possibility of fraud, the federal government actually paid providers more to conduct urine drug tests in 2014 than it spent on the 4 most recommended cancer screenings combined. There are some winners and some losers in the current system, and we have to look carefully at who's who and why. Even evidence-based interventions like methadone are fraught in this system. This excerpt demonstrates how stigmatizing even the best healthcare can be in this system. It also underscores how important the harm reduction model is and how many more places it needs to be. The media, criminal justice system, not to mention the courts. And here's a tiny portion of a transcript of a court exchange with a woman in a methadone treatment program. A lot of times folks don't understand what happens after they make a report to the Child Protective Services system. And this court appearance is one of the examples of what actually happens in real life once a report has been made. A lot of times it means people are put into these impossible situations. You have here a woman who's in a program trying to defend that program to the judge who drills into, you know, do you know the doctor's name? Do you know the doctor's first name? Do you know where the doctor graduated from medical school? We're actually not allowed to share this video. I wish I could share it with you, because then you could also hear the judge's tone, which is incredibly dismissive and judgmental. Well, darling, if you've been into his office, and you know, here she is, the power dynamics are profound. She's in the position of alone defending herself, and the judge could utterly impact her life just based on the fact that she doesn't know where her doctor graduated from medical school. So again, even when people seek out and follow and succeed with evidence-based programs, they're stigmatized, demeaned, and mistreated. I also want to emphasize that, in fact, there is no federal law that requires an abuse report for babies who test positive. And there is no definition, there's no federal definition that a positive test at birth is child abuse. Oh. So even if folks are using drugs or alcohol, it's important to know that they have rights. Knowing the law, knowing your rights, knowing the rights of patients is one of the things that everybody can do, which is why this resource is called a resource for everyday people to defend human rights during labor and birth. With regard to mandatory reporter laws, a big message that we want to convey to folks is don't report when you don't have to. A lot of times mandatory reporters in a sort of gray area, if they're uncertain, they defer to the agency. They make the report because they figure someone else in the system will do a better job than they will at discerning whether it's a worthy report, whether it is in fact child abuse. And I would just say, based on the realities of this system, that's taking a risk. That's taking risk for that person's life, the person that you're reporting. Your uncertainty, it's not worth the risk to their life for your uncertainty. So, you know, the mandatory reporter laws vary by state, but the general principle is if you have a reasonable suspicion of abuse, you should report. And I would just advise people that if you don't have a reasonable suspicion, if you don't in your gut have a feeling that there's abuse, that you're not required to report in that situation.
Indra, can you make a clarification? We have a question. We have been told that the CARA Act requires mandatory reporting of any infant who has NAS symptoms or if a mother tests positive on admission at delivery.
Yeah, and we actually have a full fact sheet that I can share with folks on CAPTA. So this federal law, it tells states what states have to do in order to receive certain streams of funding from the government. So to the extent that CAPTA has any reporting requirements, the requirements are for the state. So it says to the state, hey state, if you want to get this money, you have to have a plan. And that's literally the language in CAPTA. You have to show that you have a plan. So there is no federal law that has the authority or jurisdiction over providers. States then interpret that in lots of different ways, but even at the state, so then it usually goes into the state mandatory reporter laws. Those laws, a few, are specific with regard to positive tests at birth. But mostly what I'm seeing in states is administrative directives, interpretations of the federal law at the state agency level. So there may be state imperatives, but a lot of times there's a lot of confusion on this specific law, which is why I bring it up. I mean, CAPTA is very clear too, that it is not defining a positive test at birth as abuse or neglect. So I think it's perfectly reasonable for states to interpret that to mean that reporting could be de-identified. It could be anonymous reporting. It could be collections of data at the facility level. It could be handled by agencies other than the Child Protective Services agency in the state. So this is a very dynamic area that I know a lot of states are actively working on and figuring out how to interpret it. And that's why we're trying to spread the message that there's a lot of foundational problems to the existing infrastructure. We should be cautious about adding on new requirements within the context of that infrastructure because it pretty much guarantees inequitable and unjust outcomes. The other problem with mandatory reporting is that it actually was never studied before it was implemented. now, since it's been implemented about 40 years, studies have been done, and there's no evidence that suggests mandatory reporting does what it's supposed to do, that it prevents child abuse, that it reduces child abuse. So at this point, I think it's worth having a critical posture towards these policies, instead of just assuming that they're based in evidence or logic or something that's good and helpful for people. The other problem with mandatory reporting laws is that they undermine the therapeutic relationship and really drive people away, and I think particularly pregnant people, away from care. And like Rose suggested, one thing that providers can do, taking a harm reduction approach, is to be really forthcoming with folks. Let them know what your duties and obligations are, when and where you're going to have to report what, so that they can make informed decisions for their own lives. So there are some innovations and opportunities, I think. Number one, people can improve things for pregnant people who use substances by improving things for pregnant people in general. One way to do this is assessing patient-provider interactions. There is this Mothers on Respect tool, which is a reliable, patient-driven quality and safety indicator co-developed by mothers that can be applied in different settings to measure the nature of patient and provider relationships. That's through the Birthplace Lab. And number two, you can improve things for pregnant people with substance use disorders by improving things for anyone with a substance use disorder. For example, privacy and confidentiality equal good care, no matter who's receiving it. In addition, you can seek solutions that don't just satisfy the law, but improve or go beyond the law. You can also oppose punitive policies and not participate in them. Practice civil disobedience. And at the end of the day, ultimately, use your power with discretion and try to at least consider the potential impact on the people who you're working with. In terms of interpretation of CAPTA, New Mexico's state law is a good example I wanted to share. It actually says explicitly that a finding that a pregnant woman is using or abusing drugs shall not alone form a sufficient basis to report child abuse or neglect to the department. And a volunteer, contractor, or staff of a hospital or freestanding birth center shall not make a report based solely on that finding. So ultimately, I know I may have left more things up for discussion and debate, but I'm open to any questions and comments, and you're welcome to contact me even outside of this webinar. Here's my email address. And with that, I'll turn it over to you, Anne.
Thank you so much. I've actually never been on a webinar where we go over and there's still 91 attendees here. So I would just like to take this opportunity. I actually have to go at 3:30, but I'm happy to stay on until then. If anyone has questions or would like to continue the discussion, like I mentioned in the chat, I can unmute you and you can ask questions directly. So just put your name in the chat or put your questions in the Q&A, and I'll wait for a little bit, and if we don't have anything, we'll move on. Oh, Colleen said something nice about this webinar being the best one since she started working from home. And I agree. I think every presenter was really engaging and gave us a lot of information to think about and act on. And I hope the other attendees feel the same way. Do the presenters have any questions for each other? Do you want to see how the information resonated with attendees? I'll just keep waiting. And if nothing comes in, I will say goodbye to everyone. Okay. So, Oh,
This is Karen Martineau. Thank
hi,
you for
yeah, go ahead.
unmuting me. I'm a doctor of nursing practice, new graduate, and I did a project piloting one key question at Arizona's largest substance use disorder program. And this has been such a great webinar. Thank you so much for hosting this. And it just, the more I learn about this, the more complex it becomes, and the importance of having different types of thinkers, not only recognizing sort of the intersectionality of our patients' needs, our clients' needs, and where we provide care, but with the intersectionality of the sort of experts that we need weighing in on this subject. So it was so great to hear from lawyers and physicians and nurse practitioners and policymakers all together. It was wonderful. I wanted to bring up the point that our last speaker brought up as well about her Mothers on Respect tool that I'm not familiar with, but I'll look up. With my project, one of the things that was really important to me was that I was measuring that client experience, because I was doing something new and delicate by talking to women about family planning in the first week of their residence at a recovery program. So this is something that when I did my lit search, there's very few measurement tools out there. So I just want to open up that conversation to others who might want to weigh in, or if anybody has questions for me with what I used. Just wanted to bring up that talking point.
I will just mention again that that's developed through a place called the Birthplace Lab, and they have a number of community-based and developed tools. So I really recommend going to their website. I think it's birthplacelab.org.
Okay, so I think people's brains might be fried, which I can totally empathize with, but I'm also very energized. If you have any questions regarding CEUs or wanting to contact any speakers or getting more information, please email me. You should have that in the registration that you got. And then we'll post the slides and the recording on our website after, and I'll send out a post-event survey as well for CEUs. Thank you to all our speakers, and I hope everyone has a good rest of their day.